Lindsay, just Lindsay, question number one. Respiratory distress syndrome, which is regard period most consistent with ARDS, bilateral pleural fusion. ARDS shows bilateral pleural fusion, also bilateral granularity and patchy defined opacity. Number two, C2P is negative for pulmonary embolism, concerned that the patient has pulmonary embolism, but advised to offer no point investigation or anticoagulation required, because if C2P is negative, then the pulmonary embolism highly unlikely. Question number three, HRCT is ill-defined centrilobular ground glass nodules, more pronounced in the mid and upper zone, most likely diagnosis. Respiratory bronchiolitis is associated intestinal lung disease because HRT is ill-defined centrilobular ground glass nodules, more pronounced in mid and upper zone, so respiratory bronchiolitis in ILD is most likely diagnosed. In discriminative intestinal pneumonia, DIP, there is ground glass opacity in PACES. In UIP, there is honeycombing. In SIP, non-specific intestinal pneumonia, there will be more ground glass opacity and less honeycombing. In cryptogenic organic pneumonia, there will be multifocal bilateral consolidation in the lower lung zone will be involved. But here, the diagnosis is respiratory bronchiolitis intestinal lung disease. It is mid-upper zone ground glass opacity. Question number 4, regarding bronchial artery embolization is false. The abnormal bronchial artery is embolized at its origin. They are false regarding bronchial artery embolization. Question number 5, widespread emphysema consistent with the history of smoking. Narrowing of trachea caused by an intraluminal mass associated with circumferential area of soft tissue that extends into the pericardial space, most likely causes squamous cell carcinoma. The narrow trachea is caused by squamous cell carcinoma, most likely. So then he has history of smoking. Narrowing of trachea is most likely squamous cell carcinoma. Number 6, comminuted pulmonary fracture. CT test shows widespread peripheral areas of conjugal falsification and air path consolidation, most likely diagnosis fat embolism. After pre-month fracture, usually patient gets fat embolism. Question 7, which imaging findings on HRCT support diagnosis of NSIP? Ground glass opacification. The NSIP looks like a glass pane. NSIP, if you've drawn and here, so NSIP shows ground glass opacification. So 8, left radial pulse is weak and the systolic blood pressure on left side is reduced by 30 mg. Doppler ultrasound shows reversal of flow in the left vertebral artery, most likely underlying pathology. Critical stenosis of the origin of the left subclavian artery. This diagnosis is subclavian steal syndrome. 9, collapse of the nasal turbinates. Inflammatory markers are elevated. Nasal biopsy shows inflammatory infiltrate and cartilage causing dissolution. Narrowing of the airway, what is likely called relapsing polychondritis. And these collapse on nasal terminates, and then inflammatory markers, infiltration nasal bone, so it is inflammation, relapsing pericarditis. 10, suspected pulmonary edema. Depends on which of the following features could not be attributed to the cardiac failure and would make you doubt the diagnosis. Unilateral renal oligemia. This is watermark sign. Now, what this is seen in pulmonary embolism, and so it's not seen in cardiac failure. Unilateral renal oligemia is seen in pulmonary embolism. So 10, which scan pattern would be in keeping with low probability of pulmonary embolism? Perfusion defect with a rim of surrounding normally perfused lungs shows low probability for pulmonary embolism. Question number 12. Man has kept pigeons. Shortness of breath. HRCT is quite marked pulmonary fibrosis with areas of honeycomb formation. Which part of lung is spared by the purpuratory process? Posterior costopenis sulci. When patient has epidemic pneumonitis and there are marked pulmonary fibrosis with areas of honeycombing formation, so the part of lung that is spared is posterior costopenis sulci. Question number 13. Patient undergoes intravascular stent graft repair. Increasing aneurysm sac diameter without any evidence of endoleak, where is diagnosed type 5 endoleak. Type 5 endoleak is due to tension, endotension. So it is increasing aneurysm sac diameter without any evidence of endoleak is diagnosed as type 5 endoleak. Question number 14. You are undecided as to whether to carry out a core biopsy with a coaxial system or a fine needle aspiration. Which factor should have the greatest influence on the diagnosis decision? As availability of such as a pathologist, he will tell us that which one to do is coaxial system or fine needle aspiration. Question number 13. Hemoptysis, sinusitis, reduction in glomerular filtrate rate, and areas of bronchiectasis, bronchial stenosis, and thickening, most likely diagnosed vaginal glomerulomatosis. The lung involvement, nose involvement, and kidneys involvement are seen in vaginal glomerulomatosis. Question number 16. Drug JVP is elevated. Such structure shows prominence on the right side of the heart with asymmetric enlargement of the central pulmonary arteries. Patcholeukemic vascularity is also evident, most likely diagnosed chronic thromboembolic pulmonary hypertension. Now, prominence on the right side of the heart and then asymmetric enlargement of the pulmonary arteries and ischemic vascularity is also seen, so these are all features of chronic thromboembolic pulmonary hypertension. Question number 17. Multiple cavitating lung lesions. Some of these lesions are noted to have surrounding condylar oxygenation, which are these findings most comparable with melanoma metastasis. This is called halo sign. When there are cavitating lung lesions and then surrounding with condylar oxygenation, this is called halo sign. Halo sign is seen as melanoma metastasis. Question number 18. Which statements are regarding gastrointestinal bleeding and MCTT is true? Acute GI bleeding can be intermittent. Failure to demonstrate active bleeding does not prove cessation of bleeding. Now, this is true regarding GI bleeding. Acute GI bleeding can be intermittent, but it may stop, it may continue, and failure to demonstrate active bleeding does not prove cessation of bleeding. Question number 19. Solitary pulmonary nodules. What follow-up would you recommend? CT scan within 12 months for both. If unchanged, then both need a follow-up CT within a further 12 months. So if there are two solitary pulmonary nodules, then what is the follow-up recommendation? First CT scan within 12 months for both, and if no change, then again after 12 months the CT scan. Question 20. Persistent consolidation. CT shows jaundice, opacities, and consolidation of almost the entire left lower lobe, lung delineated by the major fissure, most likely pathology, bronchoalveolar carcinoma. Then you exclude other options and diagnose bronchoalveolar carcinoma because this is the only option which goes with the seizures, contrast, opacities, and consolidation almost of the entire left lower lobe, delineated by the major fissure, so most likely pathology, bronchoalveolar carcinoma. Other options do not make sense. Question number 21. Which feature would suggest diagnosis of pulmonary artery sarcoma as opposed to pulmonary embolism? Coordination filling defect occupying and expanding the entire abdominal diameter shows pulmonary artery sarcoma. Pulmonary artery sarcoma is coordination, and it will be a filling defect occupying and expand the entire abdominal diameter. Whereas sarcoma most likely than pulmonary embolism. Question number 22. What location of the nodularity is more likely to suggest diagnosis of subacute extrinsic alveolitis or respiratory bronchiolitis instead lung disease as opposed to sarcoidosis? Central lobular region. Now, in subacute extrinsic alveolitis or respiratory bronchiolitis instead lung disease, and these things there will be a central lobular origin of the nodularity. There will be central lobular nodularity. Central lobular nodularity will be seen in subacute extrinsic alveolitis or respiratory bronchiolitis instead lung disease, and it will not be in the sarcoidosis. Question number, in sarcoidosis, I think lower zones are involved, lower lung zones are involved. Question number 22. In sarcoidosis, the granulomatous nodules are typically distributed along the lymphatic and are therefore seen along the bronchovascular bundles, interlobular septa, major fissures, and subpleural regions. The central lobular region of the secondary pulmonary lobule contains the bronchiole and therefore conditions that cause peribronchial inflammation, such as EAA and respiratory bronchiolitis and ILD, more often cause central lobular nodules. And sarcoidosis, they are distributed along the lymphatic and bronchovascular bundles, interlobular septa, and major fissures, and subpleural region. So sarcoidosis in subpleural region, sarcoidosis is seen in subpleural region, and subacute extrinsic alveolitis or respiratory bronchiolitis ILD is seen in central lobular region. 23. Embolization of the gastroduodenal artery. Which is the method of embolization? Coin embolization, distal and proximal to the posterior aneurysm. In GTA embolism, we do coin embolization, distal and proximal to the posterior aneurysm. 24. Shipbuilder. Just accurate with pleural mass. Variant mesothelioma is suspected. What factors mean that this tumor is inoperable? There is a phlegmatic disease noted on MRI. mesothelioma involves the diaphragm and is inoperable. 25. History of chronic EML. His HRCD was smoothly thickened, separate lines with intervening ground glass opacities and sharply margined areas of geographic sparing, most likely recognized pulmonary alveolar proteinosis. Now these are typical features of HRCT. There will be thickened septal lines and GGA and ground glass opacities and sharply marked geographic areas of sparing. There is a normal lung, diagnosed pulmonary alveolar proteinosis. This creates the paving pattern. 26. Which HRG finding is most in keeping with post-primary tuberculosis, cavitating parenchymal opacity. Now there will be in post-primary tuberculosis there will be cavitating parenchymal opacity, there will be absence of lymphadenopathy, and there will be many nodules. 27. Which nuclear medicine technique is most likely to prove the presence of right to left shunting? Taxane 99M labeled macroaggregate albumin scan will show the presence of right to left shunting. 28. Which regarding hepatic arterial anatomy is true? Replaced left hepatic artery commonly arises from the left gastric artery. Hepatic arterial anatomy, which is true? Replaced left hepatic artery commonly arises from the left gastric artery. Question number 29. Question number 29. Diagnosis of lung malignancy, 4 cm lesion with ipsilateral highlight and mesothelial lymphadenopathy in the 4-hour station. What is the TNM state of this small cell lung cancer? None of these. Because in small cell lung cancer, we do not use TNM staining. TNM staining is not done for small cell lung cancer. So, diagnosis of lung malignancy and then diagnosis of small cell lung cancer. Small cell lung cancer, we do not use TNM staining.